Entonces, buenas tardes a todas y todos en el auditorio y a través de la transmisión. Damos inicio a una nueva reunión académica el día de hoy titulada Predictive and Prescriptive Models for Effective, Scalable and Explainable Kidney Donation, que va a estar a cargo de Joris van den Klundert. Joris es profesor titular de la Escuela de Negocios de la Universidad Adolfo Ibanez y líder del departamento de Operaciones y Analítica. Posee una maestría en Informática de Gestión por la Universidad Erasmus de Róterdam y un doctorado en Investigación de Operaciones por la Universidad de Maastricht. Su investigación se centra en la optimización de los servicios y sistemas de salud y también ha colaborado en proyectos para diversos ministerios holandeses, la OMS y el Banco Mundial. Bueno, como siempre, la presentación dura entre 30 a 45 minutos. Luego se deja un espacio para preguntas por parte de los asistentes y a través de la transmisión. Y la presentación de hoy va a ser en inglés.
Sí.
Les dejo que...
Gracias, muchas gracias. Y gracias por la invitación, porque tal vez en inglés. Perhaps in English I can do everything in 45 minutes. In Spanish, I will need 2 hours at least. So I'm going to be very brief. And when I talk about myself, because I think it's good to talk 1 minute perhaps about myself. En Chile siempre se preguntan de qué parte de Holanda estás, de los Países Bajos. Yo soy de esta parte, University of Twente, the East. This is actually where my father used to be a professor. And then, so here's Rotterdam. This is where I did my master. I worked 18 years in Maastricht University. Perhaps you know Maastricht because they have many activities in food and public health, etc.
Wageningen is also very Wageningen. I don't know. That's the way.
Sorry?
It's very the one in green.
Wageningen. Yes, of course.
That's very famous also here because they have like a sensory lab where they do a lot of testing of food.
Yeah. Yeah, no, the Netherlands is very well known for agriculture. It's a very small country. It's the second biggest exporter of agricultural products globally. After the US and before France,
Really?
everything else. Yeah, very impressive. And Wageningen is the knowledge center of all of that. Yeah, and then, okay, I moved back to Rotterdam for a while. So, let's say 25 years ago, I got more or less interested in applying what my background, computer science and operating in health. Very few people were doing it at the time, and I started doing that because I thought, if I can optimize things in this world, we had projects, for example, optimizing cement factories and making Vodafone richer than they were already. And then at some point, I did not think it was very rewarding, so I thought, let's try to optimize something more valuable for mankind, and I decided to dedicate most of my research to healthcare, and that's what I did. I know nothing about nutrition. I'm not a medical doctor. I have no background in public health. All the things that you know everything about, I know nothing about. I know a little bit about some other things. And so in 1929, I moved back to Rotterdam. I worked in the Erasmus School of Health Policy and Management, which is I think also a very interesting and good place. And then more or less until 2017, because then we moved out of the Netherlands, and partly when I say we, so my wife and I, my wife is from Argentina, which sort of supposed to explain why I am in Chile. So our main house is in Uspallata, between Los Ixtacazores and Mendoza. And but I made a detour. I was a couple of years in Saudi Arabia, starting a new business school. Before coming here. So that's basically my background. And I think I can say I'm here because of the husband of Camila. Because, I was in 2015, I was a year on part of my sabbatical was in Chile, in the UAE, in the department then chaired by Marcos. And we stayed in touch, and at some point I expressed an interest to work here, and Marcos made it happen. So more or less the last 15 years, I've been working I've been all over the place in my research. I'm very undisciplined. I'm not a good example of, being focused and becoming famous in something that is important. But I do all sorts of things. But I have been working 15 years in optimization of kidney transplantation. And I will explain a little bit what this is about, also the relevance for Chile, and then what we are currently doing. And then at some point, when our time is up, and that will be fine. Okay, so 15 years ago, there was a Dutch PhD student who wanted to work with me in healthcare optimization, and we started working with the Dutch Living Donor Kidney Exchange Program. I will explain what that is. But it was a great opportunity because the Netherlands has the oldest kidney exchange program globally, national kidney exchange program globally, and we were able to work with them and to optimize. And the current Dutch program is working on the software that we developed then and have been advancing. And then with some other colleagues from Europe, we got connected and we started a European project, an EU cost project, and it was quite successful. We had people from all over the world actually joining. And the EU asked us to do a second project, and now they're even asking us for a third project to do a pan-European kidney exchange, as they call it. And also my funders grant is on this topic. So I'm in this area for a long time, and I'm going to give an impression of all of that work. And here, so I'm going to talk about kidneys a lot. And this, as we chatted a little bit, this is a very heavy topic in a way. Because many of you are working, I think, a little bit here, right, on how our behavior and food consumption, and this creates all sorts of health issues. Firstly, in the form of risk factors like diabetes, high blood pressure, obesity, and these are risk factors for chronic kidney disease. And actually, probably some of us here in the room, maybe one of them, I don't know. We may have chronic kidney disease in an early stage, and you can have it, and you don't know, right? You don't know. But at some point, so then you are here, you would be here. At some point, you may advance to this stage, and then you need medication, because the kidney function, the filtration of the blood is not sufficient, and this is a progressive disease. And the last stage before death is called end-stage renal disease. Right, and this is when when most people, by default, the treatment is dialysis. Okay, and this is where my talk will be positioned. Yeah, so this is around 10% of adults globally are in advanced stage of renal disease, where actually treatment would not be a bad idea. In Chile, 1 in 6 adults has chronic kidney disease. It's the 11th most common cause of death globally. It's the 4th most common cause of death in Chile, which is huge, right? The problem is here much bigger than where I'm from, so to speak. 5,000-6,000 deaths per year. And it also has a high burden of disease. One more. 9th burden of disease in Chile. Okay, so this is not a hobby for some operation researcher who wants to work in healthcare. This is a huge issue globally, and particularly in Chile. So in Chile, around 20,000 people are on dialysis at the moment, and dialysis is by far the most costly treatment also if you have end-stage renal disease, and this is eating 30% of the auge budget. So this is a huge societal burden also, right? And life expectancy from the start of dialysis is more or less 4 years. So this is not good news. You could obviously if you have end-stage renal disease, it's good to be on dialysis, but it's not happy news. It's much better to receive a transplant. So to have a new kidney. We have 2 kidneys. Obviously, if you're on dialysis, none of them is working as they should be, right? Because with one well-functioning kidney, you are perfectly fine. So if a donor, right, a deceased donor, so that is someone who has passed away, if they are willing to donate, they can donate 2 kidneys. And with one donated kidney, or sometimes 2, the life expectancy is around 10 years. This is from the US. Right, and most people who receive a transplant maybe 50 years or 60 years, right? So it's not, some people live 30 or 40 years. And actually with a donor, with an organ from a living donor, the life expectancy is the best. I think right now the average survival would be close to 20 years, but 15 years is more normal, or at least what you can expect. And so this has the fewest complications, therefore it's also the most affordable because you don't need medication, etc., right? And it gives the best quality of life. So this is the most cost-effective and by far the preferred treatment. Right, living donor transplantation has arisen especially because of the shortage of deceased donor organs, but there are actually also good reasons to prefer this, not only. Sorry?
We might be a poor university, but our board is very interested.
But it doesn't have a negative health impact, if I think. Okay, so I better not touch it, I understand, or am I? Okay, so some facts about Chile. So we know already that there are around 20,000 people on dialysis. So let's hopefully all people with end-stage renal disease are on dialysis. There are around 2,000 people waitlisted for transplantation, which is 1 in 10, right? Of the people on dialysis. 1,300 of them are active. Some people are not active because they have another disease or condition, or right, prefer not to be transplanted right now. And these are the monthly numbers of transplants. Oops, I deleted. So I think if I remember well, blue is total and red is living, or blue is disease donation and red is living donation. So both happen in Chile, but you can see that living donation is very.
That's absolute number. Yes. Nobody.
Yeah.
And that's the one you said altruistic?
No, this is altruistic. Okay, so normally the living donation. Why and how does it happen? So the easiest or the most accessible form of living donation is someone in your family or a neighbor or a friend is willing to give a kidney to you. Right? And now I'm going to talk. Let me immediately address that. But it can be that the person who is willing to give you a kidney is not compatible with you because of blood type incompatibility or because of HLA incompatibility. Right? So your immune system may be able to recognize that this kidney is not yours and then attack it, and the transplantation will fail. So what do you do if you have a willing donor? Let's say your brother wants to give you, or your sister wants to give you a kidney, but you're not compatible. Then you look for another pair of donor recipients who are also willing, but not compatible. And perhaps you can swap the donors, right? And then both can have a transplant. This is called kidney exchange. And I will talk about this a little bit more. Because we can also do it with 3 pairs, right? You can make a never-ending chain even. This is done, all of this is done. And then it can also be that someone even says, okay, I'm alive, I have 2 kidneys, I only need 1, hopefully. I'm going to donate one of my kidneys to whoever needs it, without knowing them even. In the UK, it has to be anonymous. And then you can save a life. And perhaps with your kidney, you can give it to a pair and the donor of that pair gives it to another. And so with your altruistic donation or my, you can save, in principle, infinitely many patients. Right, and that's called altruistic donation. In many countries, it's not allowed because they are. So donation is very much regulated to avoid people donate for money, right, or to avoid organ trafficking, etc. Sorry?
The meaning of the living donor? Do they have a minimum?
I'm not sure. I suppose so.
Yeah, but I don't think a person of 20 to 25 can give that.
I would say if you're legally adult by law, you can.
Yeah.
Yeah, no, I agree. I'm not a legal expert. I don't know living donors that are that young, but I know that people are a little bit older who have done it in their 30s or 40s, yes. Okay, so just to explain a little bit the space where we are moving. So here, this is sort of the default stage. Patient has end-stage renal disease. Hopefully this patient is on dialysis. And then, but this is not where you would like to remain, right? Because your life expectancy is pretty low. So you can have, hopefully you are on the wait list and you get a deceased donor transplant sometime, but this waiting can be very long, right? I mean, in Chile, we know that there are 2,000 patients on the wait list and what was it, 20 or 30 per month get a transplant, right? So don't expect that if you enroll in the wait list that you will have a transplant before you die, right? That probability is actually not that big in Chile. So you can look for a living donor, not that. Your brother or sister, and if that doesn't work, well, if you have a willing living donor but you're not compatible, you can participate in the kidney exchange, right? So these are sort of the stages that exist, and obviously whatever we do at some point, even people without renal disease, at some point we pass away. Yeah. So in the optimization, what do? We try to optimize these exchanges, but also in relation to all the other possibilities. Okay. Yeah. And so, in general, globally, there's a huge shortage of organs, diseased or living donor organs to transplant. So someone is deciding who gets the transplant and who gets not, right? I mean, this is a very awful decision, but in a positive way, which lives do we save? And then obviously, because the transplant is considered life-saving, what all these programs typically focus on is to maximize the number of transplants. Right? Every transplant is a life saved. And that is sort of the main objective in let's say the research that I've been doing in the last 5 or 8 years. I tried to move away from maximizing number of transplants and to look at effectiveness, cost effectiveness, and then not by simply measuring how much lives do we save, but how much healthy life do we gain in QALYs. Everybody knows what a QALY is in this room? Yes? Okay, then I'm going to save some time on explaining QALYs. So this would be, let's say, your QALYs without the transplant, and this would be your QALYs with the transplant, and the difference is what you get. Okay, this we already did. Okay, now you know that I'm a fan of maximizing QALYs, but suppose that we have the wait list, and now an organ becomes available, and then the question is who do we give it to, right? And you could, let's do this optimally. I'm an optimizer. So we could give it to the patient that is waiting longest, right? That sounds pretty fair. The patient that maximizes the QALYs, that's the most effective solution. The patient that is hardest to match, some patients are really hard to match, and if I can match them now, perhaps this is, the last time that we could find an organ for them before it's too late. Or I could say, well, because of these compatibilities, I'm going to choose the patient who matches best with this donor. Right? All of these are very plausible and noble criteria, but we cannot do all of them at the same time. Right? Any preferences in the room?
I have a question. The first one that is longest in the waiting, I don't know, that is in the dialysis for 3-4 years. The result of the transplant is the same for a person that was starting dialysis?
Very good question. No. No, and what also can happen is that on dialysis, your immune system can learn new genes that are not your own, and you can become harder to match, and therefore the result of the transplant will be worse.
Okay, so it's better to match the perfect, right?
Exactly. So people should try, this is called preventive transplantation. Yeah. Yeah. Very good. Yeah. That happens.
So 1 and 3, why 1 and 3 are different? Because they
1
are
and 3
kind of the same. Like when you are hardest to match, like your longest, you will be waiting for long.
Yeah, but I can be very hard to match and just joined yesterday, right? I can be a new patient. So I agree that it's likely that hard to match patients are around already a long time, but there could be a new hard to match patient. Yeah. Yeah. Good question. Okay, and here are some of the things to have in mind. So, for example, women who have been pregnant, their immune systems are better developed, and they know better to recognize organs that are not their own. So they are less likely to be compatible, for example, with a spouse or family members, because these are the genes that you learn. So that makes them hard, and that may lower their qualities, right? So we should let's not do women who have been pregnant, because that is not effective. Also, older people have lower qualities, like you said. If you have been on dialysis a long time, that may impact. There are compatibility differences between ethnic groups, right? So, for example, in the US, it's well known that most of the donors are white, and many patients are black. And if you're from one ethnic group, you're more likely to recognize an organ from another group as foreign. So that makes the black patient harder to match. Right? Yeah. And you can also, people get retransplants sometimes, right? Because at some point your immune system finally understands that this kidney is not your own, and then you need another transplant. Now, if you have been so generous to accept a poor transplant the first time, then you may need the second transplant sooner, but you have become harder to match because your immune system is more capable of recognizing a foreign an organ, a donated organ, and that would give you lower priority, perhaps. So on the one hand, we want to maximize effectiveness and quality, but without let's say, side effects that reduce equity, right, or cause inequality or disparity, or all these words that are around. Yeah. So I will use the word equity a lot. And equity is the absence of unnecessary, unfair, and unjust inequalities. Right? So if you are a blood type O patient and there are few type O donors, then you will not have the same probability of a transplant as a type AB patient. Nobody can do anything about it. That is an inequality that may be equitable, but some inequalities perhaps we can do something about, and those are the ones that we want. And then in what sense? In how long do you wait until a transplant, or your probability to transplant, or quality? There are so many metrics that you can use to define equity, right? And I will talk a little bit about all of them, but I will be still primarily interested in the health outcomes in the quality. Okay. Yeah, I think all of this should be easy for you to know. So in the US, it's getting better, but I mean, just to paint a picture for the US, most of this research is from the US, where the waiting list has 100,000 patients. And so that's 50 times at least what it is in Chile. And every year, it's getting a little bit better, but let's say 30,000 new patients enter, and only 15,000 are matched. And now you can calculate that the wait list is stable, that the other that there are also 15,000 who leave the wait list without the kidneys, right? So this is obviously very sad problem. 5,000 of these 15 get a living transplant, and 10,000 leave without it.
Joris, one question. So, I mean, small countries will of course have problems with people. Do you know if there is any cross-country agreements to maybe enter into a higher network and maybe get kidneys with more?
So this is exactly what we are working on in Europe, right? So the project EuroCap is exactly to join all the exchange programs in Europe for the workforce, right? Definitely this is a big improvement. Yeah. Yeah. Actually, in the UK, or in the USA, it's interesting because in the USA, obviously, much of this is privatized. So there are all these competing programs, and they are small because there are so many, right? So, on the other hand, in the US, the good thing is that patients can subscribe to many programs and then see where they get served first. So there have been blood type inequalities in waiting times in the US, and therefore also in survival and in probability to transplant, and also between ethnic groups. There are inequalities in the US, and so much of the research, also of our own, is devoted to trying to equalize this as much as possible, right? As equitable as possible. Where's my point here? Okay, okay, so what I wanted to talk about a little bit, how much time do I have? 20 minutes still?
Mhm. Yeah.
Okay, so suppose that we want to maximize qualities. Now you don't know how much qualities you will have if you do a transplant, because you don't know how long someone is going to live, right? So we can only maximize expected qualities or expected qualities gain. We also don't know how much qualities a person would have if we don't do a transplant, because some people may live on the wait list for 10 years. So we need survival models to predict qualities. And that means without the transplant, with the transplant, and with the transplant for the patient, but also for the graft, for the organ. How long does this organ function within the patient? Because when the organ stops to function, we can still do another transplant, right? It's not. So there's a difference between patient survival and what is called graft survival. And most of the research is done by clinical people, so most of them are interested in the graft survival, because whether the patient died because of a traffic accident or, stroke, that is not, the nephrologist cannot really influence that. Okay, and so the standard survival model is a Cox proportional hazard model. Do you know what a Cox proportional hazard model is? Everybody? Yeah, it's hard to say I'm the only one. But, okay, so what you have in the Cox proportional hazard model, so you have, let's say, the expected survival for the baseline patient. And then depending, let's say the baseline patient is a female of 40, and then if you're a male of 50, then your risk at every moment in time, your risk of having an event, right, of not surviving at every moment in time is proportional, right? It's 0.5 higher. And so we have the baseline group, and we have for every other person based on their characteristics, we have a proportional hazard at every moment in time. Okay, and so then we have these survival models, and perhaps we estimate them as a Cox model, or we do a machine learning model, or we do whatever, right? We try to be clever in survival prediction. And then typically there are three categories that we can select to see how good our model is, our survival prediction model. One is calibration. That's basically what we do for every model, right? How good does our predicted survival time match the actual survival time, right? And if that difference is 0, then we are non-biased and we are perfectly calibrated. And the bigger the difference, the bigger the worse our calibration. Classification is also used a lot. For example, predicting 5-year survival. Can you predict which patients live for at least 5 years with a transplant and which don't, right? And then, I mean, yeah, the percentage that you could write would be your classification measure. I'm not going to go into detail. What is really interesting in an allocation context where you have few organs and many patients, you want to give it to the patient. You want to, and so if you're interested in maximizing effectiveness, you want to know which, if I can choose between patient I and patient J, which one is expected to live longer, right? So I don't care so much about calibration, perhaps, about classification, but I want to know which is the patient that benefits most. So I want to get the order of survival, right? And this is called. So if I predict I is going to live longer than J, and this is actually happening, then this is called concordant. And if I get it wrong, I'm not concordant. Right? So I can look at 100 patients who have received a transplant, and for every pair of them, I make a prediction, and then I look for the number of pairs for which I predicted right, the order of who survived longer, and divide by the total number of pairs possible, and that's my concordance index, T index. And this is important because to decide, let's say, who is the most cost effective, if my model is not well calibrated, but so if I predict this one is 5 year and this one 7 year, and it isn't, in the end it's 10 years and 14 years, I still have the order right, I still have sort of the order right, but if I get the order wrong, it's really hard to correct my model for it. So this is a very strong measure, a very well used measure in this context. Yeah. So if you get it right for everybody, your C index is 1. If you get it wrong for everybody, that would be really, you have to be really smart. But your C index is 0. If you do randomly, you say, okay, every time I flip a coin, then your C index would be 0.5, right? So if you have a model and your C index is around 0.5, you're not very impressive. You want to be close to 1. Now, if we look at people, and that includes us researchers who develop models for the US data, this is called the UNOS database, the typical C index that people get is 0.61. And 0.5 is random. Yeah, so this doesn't look very impressive, right? And we have been working in the Fondasit, we are working for about a year, and we can reproduce this 0.61. So congratulations, yeah, with the Cox model. And so we're trying to improve with machine learning. That's part of what we are doing and what other people are doing. We're not alone on this. And then, so if you start to use more advanced machine learning models, you have black box models, right? And nobody really knows what these models are doing. And then at some point you have your two patients, I and J, and then you say, okay, patient I, you live longer, you get a transplant, and then patient J will ask you, but why? Right? I'm waiting longer, I'm older, or I'm healthier, or whatever. I think I should get the transplant. And if your model has no explanation, that doesn't look good, right? It could also be, your model could be biased, for example, could be wrong for this particular patient, and you don't know. So you want models, so yeah, if you use unexplainable models, you want to make sure that they are really good and that they are not biased. So we also look into that part, the explainability of the model. Yeah. And in a way we are here, so we try to optimize effectiveness, but together with equity. So we are trying to find a good solution in this space for survival models. And we are okay with low explainability if it improves a lot, but perhaps we want models to be as explainable as possible without sacrificing too much effectivity for equity. Okay, so this is one study that we did where we compared Cox models with survival decision trees and random survival forests. And I'm going to be very brief. What we see, all three of them have have a higher C index for males than for females. So this is inequitable, right? The prediction itself is already not equitable, you could say, or not, is biased. You see also biases between ethnic groups. For example, Hispanics are easier to predict apparently than blacks. The blacks have a C index of 0.65, 0.67, 0.6, very close to 0.5, right? It's almost like random predicting. So that is not very encouraging. But the machine learning models did not do better than Fox in these experiments. And we could also show, but this is luckily a little bit better, but then if you implement these three, if you implement an allocation mechanism, you have an optimization algorithm for allocation, you can use these survival estimates from the Cox or from the survival decision trees or from the random survival forest. That does not generate huge, so whichever you choose doesn't have a huge impact on inequities. But we did find that the Cox model actually generated better results after allocation, typically, interestingly. And that is
Joris?
Yeah.
Can you explain a little bit how do you run this model? So the data from where it comes from?
Yeah. So
And what I'm thinking is that data is also not equally distributed. So you have less data from some groups and maybe differences in quality. So you can comment a little bit on how do you build the model?
So we're very fortunate. So we have the US data. Everyone can access the US data, by the way. And the US data are all kidney transplants since 1980 something. And so it's mandatory to report. The data quality has improved over time. And you have I don't know, there are endlessly many characteristics of patients, etc., treatments. So that's a huge database. We also have the Eurotransplant data. This is not an experiment. And all of these data, they all have some quality issues. I think in the US, it is fair to say that, for example, missing data are more likely for, let's say, socio-economically more vulnerable groups, and therefore also, for example, blacks. It's also definitely the case that blacks are less likely to even enter the wait list. So there's also an issue of data imbalance, right? So they are less well represented, and therefore, if you fit a model, there are fewer data on black patients, and your model is likely to get biased for the whites because you simply have more whites. So I don't present it here, but for all of these studies, also for the next one that I present, we also correct for data imbalance. Yeah. And it doesn't really make a difference, perhaps also because the numbers are huge. But it does make a little bit of difference. So we did not find in this experimental study that let's say the non-explainable models did better than the Cox. Right? Let's say Cox is a very explainable model, although Cox models are also more complex than we might think. So we did not see yet a benefit of machine learning. We also did a systematic review. This was in a way very complex because we did a systematic review on the relative performance of prediction models, which is not something that you can, easily do. It was a huge work, also statistically. And again, Cox was among the best performing models. Simple logistic regression is not recommended, but Cox is, it's around it, but standard. And none of the machine learning models that are reported in literature, consistently outperform Cox as yet. We do have much better ideas now of what these machine learning models should actually be doing, but I think there is space if you want to move beyond this 0.61. You need machine learning. Cox is not going to do it for you, but so far, not really. And something else we did. How much time do I have?
10 minutes.
10 minutes. Okay, great. So we thought actually this 0.61, that's really annoying. It's so far from 1. Perhaps there's a reason for it, right? And it's not that all these models are so bad. That cannot be the case. Perhaps 1 is not possible. perhaps the best possible is much lower, and then 0.61 is not so bad, right? So we looked at upper bounds for the C index under a proportional hazard assumption. Yeah. And basically, I thought there was some animation here. No. Is it here? No, also not. Okay, so basically what we did is we said, okay, suppose that we have a model that predicts perfectly. And so suppose that someone passed away after, let's say here, 300 days, right? Then this person has a hazard ratio of 1, because this is the baseline patient, basically. Now suppose that another patient passed away after 500 days, then this corresponds to a hazard ratio of 0.5, perhaps, right? So which hazard ratio gives me exactly the actual survival of each patient? So if I have because this is what these prediction models try to fit, right? So that ideally, what they try to do is to get for every patient to predict exactly the actual survival as the expected survival. So you can think, okay, suppose that for every patient, we predict, we have a hazard ratio that gives me exactly their actual survival. No model could do better than that, right? But then still that doesn't give me a C index of 1, because a C index of 1 means that I get the order right for every 2 pair of patients, which is only possible if these dates are deterministic, right? But if my hazard rate is, let's say, 0.5 and another person's hazard rate is 1, I could still have a shorter survival, ultimately, than this other person, because it's probabilistic, right? Nobody guarantees me that I will live exactly 500 days. I could have an expected survival of 1,000 days and die after 1 day, right? So you can never get this right for every pair because of the randomness that exists for every patient. Now, suppose that we have all these hazard ratios correct, then you can ask, okay, what is the C index that I get in that case, right? So I perfectly know everyone's expected survival, at least according to the data. What is the C index that I would get? And if you do this for the US data, you get the C index of around 0.75. So you could never predict better than that, because the rest is sort of the randomness of our lifetimes, right? Of our survival. And then the 0.61 looks a lot better, right? So now this is like the explained variance, right? I think this is a phenomenon that you know very well. So the explained variance is like almost half, which is still not, very good, but it took, I mean, you can publish studies with an explained variance of 0.45, right? This doesn't look bad at all, actually. Yeah, so this is something that we are about to submit. I think this is a huge improvement to the literature. And this upper bound is still on the proportional hazard assumption. So you don't need any advanced assumptions, or you cannot use any more advanced assumptions and still have this upper bound. Okay, and what is really interesting also, so this upper bound is pretty much invariant to ethnic groups. The upper bound is more or less the same for all ethnic groups, but the actual performance of the Cox models differs a lot among the ethnic groups. So let's say this explained variant, we call it the discrimination ratio. For Asians, it's pretty good, and for blacks, it's very bad. Very bad, actually. Yeah, so the current Cox models predict survival for black people much worse than for Asians. And that is not because of the predictability that we capture with the upper bound, right? There's something wrong with the Cox model, not with, let's say, the hazard rates that are so wild. So this is really, this really indicates that we have a task to look at more equitable prediction models. And then perhaps finally, now I'm moving to a study from the Netherlands to conclude. So if you do all of this and you have all these survival functions per blood type or per age or per sensitization level or whatever, and you use this in such a kidney exchange program, here in the kidney exchange program, when you make decisions about which pair is matched, which patient is matched with which donor, etc., or with which altruistic donor. How much do you gain, right? So here we show as a reference, without the kidney exchange program, all the patients, this is from the Netherlands, all the patients from the Netherlands over time that have participated would have an expected survival time of 0.6, 6.45 years, 6.5. And with the cap, if we would know exactly what would happen in the future, right, if it would be clairvoyant, we could create 10.9 qualities for them on average. Obviously, you cannot do this in real life because you don't know, who's about to die or which pair will enter the cap tomorrow. But this is sort of an upper bound that you could get here. In real life, if you maximize the number of transplants, you can gain around 9 qualities on average for a vacation using a cap, which was compared to 6.5 without the cap. Right, and 10.9 the upper bound, so that is like 2/3. We close sort of 2/3 of the gap between doing the very best and doing nothing. If you don't maximize the number of transplants, but you maximize qualities from a cap, you can gain another 0.2 qualities compared to simply maximizing the number of transplants. So per patient, you can get, another 2 or 3 months. Let's say three months of a poly, of not perfect health. And what we were also able to show, so if you have the right survival models, etc., and you use all of this in your allocation, none of the groups are really significantly worse off. So in that sense, at least no one is disadvantaged. I'm not saying it's equitable, but no one is disadvantaged. And some groups really benefit considerably. Especially here what is this? This is sort of these are the patients who have are not so hard to match. So for them, it becomes a little bit better. And that is because they bring more qualities, right? These are the ones that are likely to live long with their graft. Interestingly, if you do this, then the number of transplants is a little bit lower, but not significantly. As far as we simulated, but that could definitely be a drawback, right? You could say, well, and if you maximize the number of transplants, you have more transplants, perhaps, but significantly lower quality. For the Netherlands, it would be really important because in the Netherlands, actually by law, healthcare has to be effective and cost effective. You cannot just optimize whatever you want. Although in the current Dutch kidney exchange program, there's another policy. It's funny because this other policy does not really maximize the number of transplants only. It does many things, but ultimately it generates more transplants over time than if you only maximize the number of transplants. All right. So I hope that is an impression of my research and the research that many other people are doing together with me. And also, so we are, I think I suggested a little bit, right? What we are doing, we're trying to improve the prediction models, both the Cox models and machine learning models. We're trying to use these models to better optimize allocation in living donation and in disease donation. This may be also interesting to mention. Very interesting perspective is also from the other side. You're a patient on the wait list, and at some point you get an organ offer. And now it's up to you. Do you think you should accept it, or do you think that you should wait for the next organ that is offered to you, right? That is the optimization problem from the other side. We are starting to work on that. And then, yeah, so we are working with Eurotransplant to improve their survival with this pan-European exchange that is currently a European project. And I'm from time to time I knock on some doors in Chile, but so far without much success. But I hope, while I'm here in Chile, I would rather contribute to success in Chile than in Europe. In Europe, there are many good researchers taking care of the European stuff. Okay, that's all. Thank you. And obviously, all questions are welcome.
So, do you have information about post-transplant behavior? What I was thinking is that, maybe the variance is due that, I don't know, before the kidney I was taking care, I got the transplant and now I start having diarrhea and drinking a lot. Okay. So I was wondering if you were having some information about behavior after the transplant, and maybe this can explain why the 0.61, has like the. So I was wondering if you have some variables about post-treatment behavior.
So obviously this is a great question. What you have in the databases, this is clinical information, right? And it doesn't include how many times a week people go partying or all of those things. Yeah. So also it doesn't include, for example, medication compliance, right? Which is obviously also very important. Yeah, in the US, it's particularly annoying because many people are medicated with Medicare, and these programs only reimburse medication for a limited amount of time. Yeah, it's not very helpful. And then but these type of data are not in the databases that we have. Yeah.
And what are the variables available?
It depends a little bit. A Eurotransplant is not that much, but the UNOS database is it's like, I think like 400 predictors. Some are pre-transplant, right? So some you can only use less time of allocation, but some are with all the type of data that's after transplant, and there are patient data, donor data, and data on genetics. And we are working a lot now on the genetic data because they used to be, most of them are at the gen level, but now we have data at the allele level, which is much more refined, and even at what is called the epitope level. Yeah, so more and more impressive databases. Did you have anything particular in mind? Or?
About what variable did you consider in the
in the studies that we presented? Yeah. Okay, that's also a very good question. So for the US, they have a set of 10 predictors for the donor. These are the predictors that are actually selected by Fox models, and they together form the kidney donor profile index. And then there's four predictors for the patients. There's the EPTS, and then they use for the mismatch, blood type and 10 genes. That is it. So in the standard models, let's say the default models, the set is quite limited. And yes, so we're trying to add more predictors, but it doesn't improve a lot so far. Yeah, some people have tried everything already. That can help a little bit, perhaps. It also increases the risk of overfitting, right? Mm. So you get very good results in your data set, but if you use it to predict later results, you may have even worse results. Yeah. But that is definitely an area where we are often. Yeah. Other questions?
Sorry. I was wondering, because we group by blood type, but did you consider segregating by RH type? Because sometimes the RH group also could influence, for example, for pregnant women, if they have blood or RH. could be complicated as well, so maybe for the transplant issues, like the positive
Yeah.
and negative surveys.
We did not consider it. It may be an issue, but not that I'm aware of. I cannot say no or yes. I haven't seen it. I will look it up. Thank you.
Yeah, I was going to walk on Camila's question about the data. I actually believe that a smaller set of predictors would be better from a practical perspective, because then you need to collect less data to make it match. I mean, from a clinical perspective. So I wasn't clear about whether you were doing this based on Chilean data. And if no, or yes, how it compares to these larger data sets. I'm going to explain a little bit on this, because one of the key issues we have here is actually related to data. And of course, on capacities for running predictive models and changing the culture, but also just collecting data for these purposes is a big issue, or it has been a big issue here in Chile. So I wanted to know a little bit if you are using Chilean data, and what is your perspective comparing these data sets of the US and huge data sets. And because that's very related to actually the possibility of implementing something like this here.
Yeah. Yeah, no, definitely. Yeah, so we are in touch with Hospital Sociedad del Rio.
Yeah.
And they are supposedly the biggest, or one of the biggest transplant centers. Yeah, but we have not moved beyond being in touch.
We can comment more on the lunch.
But they are willing to work with us. But they have also said, all the data are on paper, for example. I've also, last month, I believe, I got in touch with La Católica, and I think they also, but I would like to go to the national coordinator and have the data. I think that is the proper way to do it, and not go hospital by hospital. I don't think that's how it should be done. But yes, and I have time. We have funds, right? So if this can happen, I would be delighted. But we knew from the review, and it's also not. It's also common sense. But okay, so first of all, there are protocols for survival modeling studies, and how to report them. And basically, one of the things these guidelines say. You should have the number of predictors should be less than the number of events divided by 10, right? Suppose that we have 300 patients and 20% of them have had an event, the graft has failed, that would be 60 patients, and then you can only use 6 predictors, right? So if we have a small data set, we should not be using 100. And they say if you use more advanced machine learning models, this ratio should not be 10, but 100 or something, right? Because you don't know what's going on inside these models. So you cannot use a machine learning model in Chile, basically. That's what they're saying. So that's also in the review. So we have here, this are all the results for UNOS. And these are all the results for, let's say, the rest of the world, because many of the studies in the rest of the world are from a single center or 2 centers, right? And but no, definitely that is a very important topic. Yeah. What will also be an issue in Chile is that because of the low number, that on the one hand you want to use older data because then you have more data. But the older data are less representative of current survival, right? So that is also an issue that needs to be addressed.
¿Alguna otra pregunta? Y de la transmisión tampoco hay preguntas, que estamos listos. Muchas gracias.
Muchas gracias.
Estamos en video.
Actually, Spain is a very successful
Al final.